Good morning.
Good morning.
Got to be more careful. Wait a minute. When everything went off, I said, "Oh my God, I done tripped something. I done broke something."
Uh-oh.
Not saying that. Oh, the time had run out, ma'am.
Oh.
Click your next button. Click your next button. How are you?
All right. Look, I was looking for your little co-host today.
Oh, she
You
upstairs.
Oh, okay.
I may get her in a break or something. She's upstairs. She's upstairs. How are you doing?
I'm all
How's your
right, and
week?
yourself?
I'm
Uh,
good.
it's a
Good.
week.
I
Glad it's
know.
over.
I know. And then why in the middle of the week I woke up and there was like snow on the ground. I'm like, what is this out here? What is this? Then I listened to a Chicago station usually when I'm working. And they they were like, it looks like a snow globe outside. They was like snow was just blowing everywhere. I said, what is happening with the weather? I mean, I know we still in winter, technically, but really,
Yes.
but really. Yeah. Oh, everybody don't forget to do the daylight savings time or put your clocks spring forward.
No, that's next week.
I thought it was this week. Somebody told me this week.
Mm-mm.
Everybody been telling me this week. Okay, well then don't spring forward.
I checked. I was like, I don't want to be here and be behind.
Yeah. Oh, everybody don't forget to somebody.
But after it's the
It's the 14, 15 weekend.
no. Next week. Wait. You're right. It is tonight.
I was like, I know people been texting me and telling me, don't forget, because who would be still asleep would be me.
Last week was the first. Okay, yeah. I'm
Yes.
thinking it's still March. I mean, the first week. We into the
No.
second week. All right. I'm
Yes.
sorry.
This is the second week. So, okay, spring forward.
Yes. Well, thanks for reminding me.
Spring forward. Spring forward. All right, all right. Well, let's get this party started. What is this? Get rid of this. Okay. Welcome everybody to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information, news, education, certification tips, when to spring forward, when to fall back, the weather, and the prior week. But we also talk about entrepreneurship and, for the most part, the revenue cycle at large. As you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Well, let me ask, do you know what it takes to be a certified marketable medical coder? Well, before I introduce my co-host, let me share with you information on a free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey. Okay. If you're interested in getting more information about the 5 steps to become a certified marketable medical coder, we'll check out the video description for the link. Joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for several decades. In 2014, I left the bedside And that was my first foray into medical coding. During the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Okay, and how is that going?
It's coming along pretty good. I'm wrapping up one class, and we're almost halfway through another.
Oh, look at God. All right. You got on that shirt.
Yes,
Wait, hold up. Let me solo you out. Show those people your shirt. Read
this is
the coding guidelines. I love it.
please and thank you.
I love it. That was so cute. When you showed it to me, I said, that is too cute. Now, did you design that one?
Yeah, I did.
Look at you. Uh-oh. Shirt designer. Wait a minute. Wait. So now you got merch. Come on with the extra stream. You better quit playing with the people.
And I got them in a couple colors.
What? So where can we find the information about the merch?
Well, I didn't even think about selling them.
Sir. I try.
Thank you.
Try.
Yes, you do.
I try. I swear I try. I bring them to the water. The water is nice and cold.
You do.
It's clear and pretty.
But you know what though? But actually, before I do, I need to talk to my trademark attorney.
Okay. And get all of that settled up.
Yes.
Okay. I try. I swear I do. Anyway, before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Your opinion matters and is always welcomed here. So use the chat in whatever platform that you're on. Unfortunately, I'm going to have to figure out how to get my LinkedIn people over here we do see LinkedIn comments? We do see LinkedIn comments.
Yeah.
Okay. It's somebody I don't see. Instagram people, I don't see their comments. And so you told me I had to go over and
I got
to be over there. Okay. Because I want to bring the people in. If you in there and you commented, I want to let the folks know you're here and see what you're talking about and all the wonderful, beautiful things. Okay. But anyway, your opinion matters. Use the chat and let's have a conversation. Again, we bring the topics. We bring the stuff that we see. We bring the stuff that we think you need to know. We see, need to be reminded of, all of those things. And
absolutely,
we want to know what your thoughts are related to the information that we bring. All right. So if you have a question, please type Q first so we know it's a question for us and not a question amongst yourselves and we don't miss it. So for those who are just joining us or watching the replay, today we are talking about the new 2025 Medicare codes, G0545 and the ASCVD, arteriosclerotic cardiovascular disease updates. All right, but first, we must get into our church announcements. Yes.
Where them fans at?
Hey, wait, see, don't make me put all of this stuff on one of them fans and be popping it. Because I got gazillions of them, right? I bring the fans. But we got these little calmer church fans right here.
Yes.
Because I don't know, it might be a situation if somebody start popping them fans in there. I don't know. You never know. Somebody may be popping them fans in the church for real.
They might be part of the new praise and worship team.
I'm going to fall on the floor. I cannot with you. Yeah. And sometimes they be a little extra, don't they? You gotta love them.
Look, because what's the bougie name? Liturgical dance?
Don't do that. Because I am on my praise dance team. Don't do that. Not the bougie name. See what happens when a week goes by. All right. So the only thing that I have was something I got this morning, and I wanted to get y'all take, particularly for my health information professionals, because I thought some was interesting related to this. So this is from my friends over at the AMA. We haven't talked about them for a minute, but this one I couldn't let go. And it's talking about the break the glass functions in EHR that people use to access employees' patient records. And this is from their series or sessions called Debunking the Myth. So they're talking about various myths that they hear in healthcare, and they give their take on it. So in this particular one, I'm looking to see if there's an author or anybody. I don't see an author. You know, I try to be giving folks credit when they do the things, all of the things. I don't see an author. Okay. But anyway, it talks about, it says this resource is part of the AMA's Debunking Regulatory Myths series, supporting AMA's practice transformation efforts to provide physicians and their care teams with resources to reduce guesswork and administrative burdens. Okay, so debunking the myth. The HIPAA privacy rule does not specifically require that healthcare organizations universally apply extra restrictions on access to patient records of employees or their immediate family members with the quote, break the glass EHR functionality. So as soon as I saw that, I said, we got to dig in because what you talking about? What you talking about? So break the glass functions require an EHR user to enter additional authentication information and documentation of a specific business reason for accessing a patient record before they can enter a patient's chart that is subject to heightened restrictions. Not only do I know facilities use break the glass functionality, not only for their employees, but they oftentimes use them for like VIP patients. So, patients who have elevated status, if you will, within the organization, so that people don't just arbitrarily go into folks' records and be trying to be nosy and seeing what they can see to the detriment of their employment, but because they always get caught. I don't understand.
And I've also seen it in certain instances, like to access like mental health records.
Absolutely.
For people, yeah.
Absolutely. So let's see. Each access is tracked and monitored by designated security or compliance staff. We use it all the time. This feature, which is enabled if an organization requested from their EHR vendor, is intended to further ensure protected health information privacy for certain types of patients by restricting access to only those individuals involved in the patient's care. And truly, those are the only individuals that need to be in anybody's employee, VIP, anybody. Only if you have a need to know. Only if you're involved in their care, which extends to, our revenue cycle folks, because oftentimes they are involved in the patient care by making sure things are coded and billed and all of the things appropriately. Okay. Many healthcare employees and their immediate family members are patients at the health systems in which they work, receiving healthcare services from physicians and other clinicians they work with. Some organizations, in an effort to protect those patient records from unnecessary access by other employees, may institute heightened restrictions on all employee health records, as well as patient records for the employee's immediate family members, requiring the additional step of using the break the glass function to access the record. When applied universally, such restrictions can create unnecessary, onerous steps and inefficiencies for the clinicians treating patients who work in the health system. Over the course of a patient's time with the health system, this extra effort of validation can take clinicians' time away from other important patient-facing tasks.
Uh-oh.
Employees of a health system are able to request such restrictions on access to their own medical records. Security of patient data is paramount and should be a top concern for all health systems. Protecting sensitive patient information must also be balanced with workflow efficiency. The HIPAA privacy rule does not require specific restrictions on accessing patient records, but it does require healthcare organizations to take reasonable steps to ensure patient information is only accessed when and by whom it is necessary to provide care or services. There may be other ways to provide these safeguards that do not create unnecessary administrative burden. Healthcare organizations should consider state-specific restrictions when determining how to implement additional protections on certain types of health records. Some federal restrictions, such as those regarding substance use disorder records, should also be considered. Absolutely. Break the glass protocols can also be effective for ensuring security when sensitive patient information is shared outside the health system and accessed in certain environments, for example, external emergency departments. These protocols require external users, those not affiliated with your health system, to document a clinical reason before accessing restricted records. So the takeaway from them on this debunking the regulatory myth is by de-implementing universal heightened restrictions for health system employee patient records that require the use of a break the glass function to access those records, and only enabling this feature for those who have requested such restrictions, healthcare organizations can increase efficiency for physicians and other clinicians treating those patients. For real, yeah.
Exactly.
For real. First of all, how many patients know that this is even a thing? Let's start there. So how would they even know to then request that their records have this functionality attached to it? How would you know? You can barely... Where's my tea? When I saw this, I said, Lord, here we go. Here we go. And I just, I just bowed my head in a little prayer, particularly for my health information professionals, because this is gonna cause a problem. Houston, we're gonna have a problem with all of this. So that was my church announcement for the day. I'll add this link. I didn't add it to the video description, but I'll add this link to the video description so you can share and share and share with your friends. Mr. Jesse, do you have any church announcements today?
I have two, actually. So the first one is I want to give a shout out and a thank you to Shelly. Shelly watched my Instagram live last week, and I invited her to come to my class this past Wednesday to talk about her experience being a nurse in risk adjustment.
Yeah.
And she came and was really engaging and gave the students a lot of information. And my last announcement is I have an ICD-10-CM class starting on Thursday, March 20th at 6 p.m. Eastern Time. And if you're interested and want to learn more, visit thecodingnurse.com.
Look at God. Yes. I love it. Well, congratulations.
Thank you.
And I love it when we have people come talk to students. I mean, it's one thing for us to say it, and then of course they listen to us and we'll follow suit. But to hear others also engage and have similar experiences and conversations, or even varying or diverse experiences and conversations, is always a wonderful educational opportunity. So congratulations on that win-win for everybody.
Yes.
All right. Okay, let me stop you. Stop this. All right, and let's see who's in the house today. Who we got in the house? Good morning, Carmen. Good morning. Good morning, KK. Good morning to our on the street correspondent, the crafty coder.
Yes.
Sam Spurge Craig. Good morning. Good
From
morning,
South
Blue
Carolina.
family. Sending love from Eastleigh, South Carolina. Well, welcome, man. Welcome. Welcome, welcome, welcome. Good morning, Tanika. Good morning. No boots on the ground.
Good morning.
You know, he jumped right in with where them fans at, right? You know, he jumped right in. Oh, yes. Well, thank you. I love this part of the segment. Well, thank you, thank you, thank you. I got it.
Yeah.
I got it. All right, all right. Well, welcome everybody. I don't know. Do you got people over your side on the
Yes.
probably got rid of them. Look, you know I can't multitask and do a gazillion things at one time. I see a couple people join, but I don't see any comments. But welcome over.
Yes, welcome everybody on Instagram.
Everybody on Instagram.
I see Raquel
Hey.
and Courtney, Nicole, Jay-Z, and MP Blessed. Oh, and Virtuous Woman. Oh, she says good morning from Dallas.
Hey.
Good morning.
Good morning. Good morning. I see Mona Lisa 1907 and Am Blondie 116. So welcome. All right. Okay. Well, let's get this, let the tea spilling begin. So today I'm going to talk about, and of course, Mr. Jesse, you jump in whenever, however you see fit today, because you know we in a different bag today.
Yeah, because that infectious disease add-on code, I was like, wow.
Mm-hmm.
Okay.
Right. They doing some things, right?
Mm-hmm.
I wanted to preface this with, and hopefully it all still exists. I mean, I don't know. This is what was done prior to our new administration.
Right.
I don't know if there have been any executive orders or, you know, the disbanding of HHS and all of the different things that are happening or trying to happen or whatever. I don't know if so. As of this information, I think it's still there, but it may be here today, gone tomorrow. I don't know, but I'll let you know if I find out. Okay, so today we're diving into two important coding updates from Medicare. These all come from the Medicare physician fee schedule, and I do believe I linked that. If not the entire, I don't think I put the fee schedule in its entirety, but I believe I linked the fact sheet that comes from CMS, and they put together a fact sheet for all of the regulations that, like OPS and the inpatient prospective payment system. OPS is the outpatient prospective system payment system. All of the different payment modules and systems that they have, they put together a fact sheet to kind of give you a quick and easy, dirty look at what has been finalized. And then you can always go out to the Federal Register to get the full take on what happened. Even all of the comments are actually listed in the Federal Register as well. So you can see what comments, what opposition, what support, and things that may have changed as a result of those comments. Even though part of, again, this administration wants to get rid of those comment periods. We'll see how all that works. But anyway, so let's talk about the new G0545 add-on code for infectious disease specialists and the atherosclerotic cardiovascular disease risk assessment and management codes. Okay. So here is a wonderful new opportunity for infectious disease specialists. I said, oh, well, they done got a whole carve out on their own, right?
Mm-hmm.
They doing some things over there. So I'm like, okay, where's my time? Because I don't want to run over time. All right. So CMS released a new HCPCS add-on code, G0545. This code has been effective since January 1st. So hopefully, if you are in infectious disease, you are aware. If you are, say you are a general practitioner or internal medicine provider that also has a specialty specialty in infectious disease. This would include you as well. This particular code allows specialists to bill for services separately alongside inpatient and observation evaluation and management codes. It is only for inpatient and observation evaluation and management codes at this time. So what exactly is G0545? Well, it's an add-on code. Remember, add-on codes are those codes that have to be added on to another code. They cannot stand alone. But this particular code reflects the additional complexity and intensity of hospital inpatient or observation evaluation and management services specifically related to infectious diseases. The key thing to understand is that this code was created to account for the specialized expertise these physicians bring to managing complex infectious conditions. Now, I mentioned this, but who can bill for this code? Yeah, this part is very important. G0545 is specifically designed and made for practitioners with specialized training in infectious diseases. So it's not for everyone who might treat an infection. It's designed for infectious disease specialists. So let's talk about when you can use this code. G0545 can be reported alongside several code sets, 99221 through 99223, which are your inpatient or observation evaluation and management codes. You can also use this for 99231 through 99233, which are your subsequent codes. So you have your initial codes, and then you have your subsequent codes for every day that the patient is in the hospital. And 99234 through 99236, which are your same day admit and discharge codes. So these codes are for your in and out people, but they have been admitted, so they are hospital codes. So this add-on code can be used with them as well. As with most things, documentation is absolutely critical for billing G0545 successfully. Here are the things that the physicians must document, and you should see for you to accurately bill this code and bill this code. The infectious disease diagnosis or suspected condition, any specialized evaluations, such as a review of resistance patterns or lab results, management decisions that reflect the added complexity, like changes in antimicrobial therapy or infection control strategies, and coordination with labs, public health agencies, or interdisciplinary teams. This thorough documentation ensures the additional complexity is justified for billing purposes. When I tell you, they tell you what it is you need to have in your documentation.
Yes.
You just need to follow it. It's right there. They give it all to you right there.
Now, the only thing I thought about two things is when I read the article, I'm like, okay, well, they laid it out about the requirements, and a lot of people are not going to have that information in there, though they say you have to have it. Then I thought my first thought was these people who do credentialing, because this is all going to come down to those taxonomy codes.
Absolutely, and they need to have
And
that
they, yes.
as
Mhm.
an infectious disease specialist listed there. Otherwise,
Yep.
I'm sure there's going to be some type of edit that kicks all of this out.
Mhm.
And then you'll be fighting the battle of, well, wait a minute, I am, and I do, and I this, and I that. Well, all of this can be resolved in credentialing or your CAQH profile or whatever. Just make sure that that is part of the taxonomy that you have as a provider. Absolutely right. Thank you for bringing that up. Appreciate you. So there are also some important billing guidelines that you need to know. So G0545 can be reported on multiple dates during the same hospital stay, as long as the infectious disease specific complexity is evident and properly documented for each date of service.
Keyword each.
Each date of service. Can't just keep slapping it on just because you slapped it on at first. No, there has to be documentation to justify that the complexity is there for the provider. Also, it applies only to hospital inpatient or observation E&M services. Again, you cannot use it for outpatient visits. And it excludes telemedicine. So there are no virtual visits. Again, there has to be a bed, a body, in a bed in a facility. And the other most important key takeaway, I guess, if you will, or key point to make is right now, this code is only being covered by Medicare. I don't know when and if other insurers will jump on the bandwagon, and oftentimes they do. But right now, this is a Medicare only code, or is only covered by Medicare. So this is a significant opportunity for infectious disease specialists to be appropriately compensated for their expertise. So make sure your facility is ready to implement this code correctly. Mr. Jesse, you have any other comments you want to add to that?
I just think that it's really it's a nice add-on because infectious disease, they really do a lot, especially in people who have some kind of, especially septic patients, because you have to, a lot of times they have to change their antibiotics based on different lab results, and they really do spend a lot of time monitoring their patients. So it is good that they can get a little extra compensation for that.
And I think probably due to the pandemic, it was realized that this is a whole thing, because I'm sure they worked them to death. Running, trying to figure out what is this. And I mean, even outside of the pandemic, like we have all kinds of things that are happening now. These uptick in measles cases, bird flu, regular flu, RSV. I mean, all these infectious diseases that are prevalent here during this time of the year. I'm sure, yeah, they need to be compensated for that. So, but make sure somebody had a conversation with these specialists and make sure that they're documenting appropriately, because it's easy to slap an add-on code to the additional things and potentially get reimbursed, but it's hard to be able to justify when they come back looking for your money. So make sure that the documentation is there to justify it.
And then I thought about, this is just a little sidebar. When I was working in CDI, there was a hospital I covered, and they had these two doctors. They were twins, and everybody had sepsis, and so they were dubbed the sepsis twins.
Not the sepsis twins, activate.
And I'm like, look, if they get a whiff of this, they're gonna have a yacht by the end of the year.
Wow. All right. Okay, so let's switch gears and talk about the new atherosclerotic cardiovascular disease, or ASCVD, risk assessment and management codes.
Now, before you start, why do they make this verbiage so complicated?
I don't know. I don't know.
Because I'm telling you, I was almost tempted. To run it through Chat GPT and be like, can you simplify this? I'm like, what? All right.
I don't know. I'm like, yeah, I don't know. I think it's a medical thing. They're trying to stay employed. Somebody is. Let's confuse the hell out of everybody and then let them try to figure it out. I'm like, okay, all right. Bless their hearts. Okay. So CMS created 2 new G codes included in the 2025 Medicare Physician Fee Schedule Final Rule. These codes were inspired by the success of the CMS Innovation Center's Million Hearts Cardiovascular Disease Risk Reduction Model, which produced impressive results, reducing the rate of death from any cause for medium, and high-risk patients by 4%, and reducing risk of death from a cardiovascular event by 11%. Those are significant improvements. Let's break down the first code. So G0537 for ASCVD risk assessment. So this code is billable for patients who don't currently have a cardiovascular disease diagnosis or history of heart attack or stroke, but do have at least one predisposing condition that may put them at increased risk. These qualifying conditions include obesity, family history of cardiovascular disease, high blood pressure, high cholesterol, smoking, alcohol, drug use, prediabetes, or diabetes. Family. Everybody about to get this code slapped. And I was real interested when I got this, because lately I've been hearing a lot of some of my seniors talk about when they visit the doctor, the focus on heart disease. And so everybody has had some kind of mention or some kind of documentation in their charts based on recent visits about heart disease. And so everybody, the way they were talking, like, you got heart disease, like everybody is getting slapped with this label. And I was like, really? And so as soon as I read this, I said, and now I see why. This whole assessment. So for the assessment, you need current laboratory data from the last 12 months, specifically a lipid panel, administration of a standardized evidence-based ASCVD risk assessment tool that's been validated through research. Now, they don't tell you, I think there may be a few tools out there. They don't tell you which tool you need to use or any of that, but you need to have one that is evidence-based. The assessment tool must include specific domains, however, demographic factors like age and sex, modifiable risk factors such as blood pressure, cholesterol control, smoking status, alcohol and drug use, physical activity, nutrition, and obesity. Possible risk enhancers such as preeclampsia, prediabetes, or family history of cardiovascular disease. The output of this tool must include a 10-year estimate of the patient's ASCVD risk. And this output must be documented in the patient's medical record. The risk estimator is one acceptable tool for this assessment. It's called the ACC ASCVD risk estimator. And so that's one of the tools that can be used for the assessment. Like I said, there are a few of them out there. Just make sure it's evidence-based and it has the appropriate domains on them. The risk assessment code has been assigned a work RVU of 0.18 and can be billed once every 12 months per practitioner per patient. Got that? Okay. Mr. Jesse, anything you want to add to this?
No, because I've seen a couple of tools, like a lot of, especially like cardiologists have been using that D thing for a while.
Mm-hmm.
So I guess now they're really focusing on it.
Mm-hmm. Absolutely. She says per with capital letters. Per. All right. So now for the second code. And the second code is G0538 for ASCVD risk management. So the first code is for the risk assessment, and then the second code is for the risk management. Now, for the risk management services, this code is billable when performed on a patient found to have intermediate, medium, or high risk of cardiovascular disease over the next 10 years per the assessment. Risk management services should address what CMS called the ABCs of cardiovascular risk reduction. Hi, Swap TV. They had Swap TV joined and said, hello, friends. Okay. Also medical coding B also joined. Okay. So here are the ABCs of the cardiovascular risk reduction. Aspirin, along with statins and other appropriate medications, blood pressure control, cholesterol control, smoking cessation. Specifically, the risk management services include promoting preventive services like tobacco cessation counseling and diabetes screening, medication management, including, again, the aspirin or statins. Didn't we talk about this last week, how as coders, clinical coders that we are, that you need to make sure you review the information, including medication? Did we just talk about that beautiful love letter? Here we are again today. Okay.
Yeah.
I just want to add that. Also, ongoing communication and care coordination via certified electronic health record technology, and the provider must offer synchronous, non-face-to-face communication methods. Additionally, you need an ASCVD specific, individualized electronic care plan that addresses modifiable risk factors and risk enhancers specific to cardiovascular disease, is established, implemented, and monitored, and incorporates shared decision-making between the practitioner and the patient. The ASCVD risk management services can be performed by a physician or qualified health professional who may furnish E&M services under Medicare. Patient consent must be obtained, and since risk management is not considered a preventive service, cost sharing may apply. That means for you Medicare patients that you would possibly have to pay a deductible or have your deductible satisfied, and could have a copayment depending on what type of Medicare service you have, like your managed Medicare, et cetera, et cetera. Anyway, this code has also been assigned a work RVU of 0.18. So, to summarize the key takeaways from our discussion today. First, both of these codes update represent valuable new revenue opportunities for appropriate specialists. For infectious disease physicians, G0545 acknowledges the complexity of their work in the inpatient setting. For primary care and cardiology, the ASCVD codes create a reimbursement pathway for important preventive work. Again, all of these specialists and non-specialists, because primary care encompasses a lot of folks, here are some additional opportunities. We talked about the documentation. It's going to be the key factor in all of this and making sure that your documentation justifies, as always. Second, and here we go again, documentation is absolutely critical for both of these codes. Again, for G0545, you need specific documentation of the infectious disease complexity. For the ASCVD codes, you need proper risk assessment documentation and management plan details. The details matter. Make sure they're documented. Third, remember that G0545 is applicable to multiple dates during a hospital stay. As long as you document the specific infectious disease complexity for each date of service, you can bill it multiple times during the same admission. Fourth, the ASCVD codes require proper risk assessment tools and follow-up management. Make sure that your providers are using validated tools and creating the required electronic care plans. Fifth, practices should update their charge masters and billing systems immediately, if not already done, to capture these opportunities. If you wait too long, you're leaving money on the table. And who wants to leave money on the table in today's tumultuous times?
Especially now, not right about now.
Not now. You need to get every red cent you can. Finally, the revenue impact of these changes could be significant if implemented correctly. Again, for infectious disease specialists who see many inpatients all the time, G0545 could substantially increase revenue. For practices with patients at risk for cardiovascular disease. Did y'all hear the things that the people that they're looking at, the people that they're doing the risk assessment on? That could be everybody that walks through the door, pretty much. So for the practices with patients at risk for cardiovascular disease, proper implementation of the ASCVD codes could create a new revenue stream while improving patient outcomes, which is the most important part in all of this. All right. Any things you want to add to this, Mr. Justin?
No, outpatient is not my thing.
I know. But it's inpatient code too.
Well,
I tried to include you a little bit. Now there's no diagnosis codes on this, but
listen, I'm telling you, I might have to email the sepsis twins and put them on some game.
Put them on some game.
Yeah.
Like, hey, let me tell y'all something. Were you familiar?
Yeah.
were you aware? You about to have the Wonder Twin or the sepsis twins activate for real.
For real. I'm telling you, once they hear about this, it's over.
Right. All right. Well, let me ask you some questions to consider about implementing these codes in your practice. So take a moment to think about this. Has your facility implemented or updated its charge master for these new codes? What documentation templates might you need? Y'all know folks like a good template.
Yes, they do.
They love a good template. So maybe thinking or reaching out, grabbing some of those, especially for the cardiovascular codes, grabbing some of those risk assessment tools and seeing which one you want to use, and then creating maybe an appropriate template for your providers may be something to help them with their administrative burden in documentation. I don't know.
But I do think it's interesting that they have a code for the assessment and then a code for the management, which, and you think about it, it does make sense.
It does, because you will have different people managing. And so that's where like your primary care physicians can jump on, because they're the ones that probably are doing most of the management and seeing the patients more frequently than the specialist, depending on the severity or the patient, how the patient presents. Sometimes come back in 5 months, come back in 6 months, sometimes come back in 2 months. So it just depends on the severity of the patient. And then the last thing to consider, how will you educate your physicians? Lord, that's going to be the important part. Not only educating them as to this potential opportunity, because that's going to get them listening, but the important part is educating them on the appropriate documentation in order to get this additional opportunity.
Yes. And the thing is, they push back about the administrative burden, but the reason why there's an administrative burden is because you have to create a template for everything to make sure that they document appropriately.
And let's talk about that, because so really, who has the administrative burden? Who's the one? Whoever puts together who does the work for these providers? Because oftentimes, can they see? I done jumped on a whole soapbox. Like, they not typing, they not doing this. Somebody else is doing the work for them. So where is that?
For real.
Where is that administrative burden really at?
For real. Because if you don't give them a checklist, it's not going to happen.
It's not going to happen. And that's so sad. Because they will be the first one seeing it with their chest. Oh my God, I have to document. I'm spending so much time documenting. Spending so much time. You're spending a lot of time copy, cut, and pasting. That's what you're doing. But did I say that?
Talk about it. Talk about it.
You can only copy, cut, and paste so much. And then, see, yeah, you done got me on the soapbox.
Okay,
you don't even read the stuff that you copy, cut, and paste in.
Tell the truth and tell the truth and shame the AMA. Yeah.
I mean, take a moment, just a little moment, and and read and say, oh, wait, hold up. Let me not put this part in there because this doesn't exist for this encounter. Get rid of it. Okay. Kind of got me worked up today. Okay. That was not even the purpose. Well, anyway, I hope this breakdown helps you implement these important coding changes effectively.
It
Remember,
really did. I mean, I was impressed. I'm like, wow, they got some stuff going on in
they got some stuff
outpatient.
going on. I said, well, let
Yeah.
me, I was like, because I haven't done, and I'm so sorry to my people, um, my fellow subscribers, because I usually do a whole comprehensive annual breakdown of the final rule on things that I think matter. And I'm going to get back to it. I promise you I will.
I don't think you're gonna have to pretty soon.
I, yeah, because it might not exist.
Yes.
Why waste your time, right? But I try to let you know, like, these are the things that came out of those final rules. And these are the things that you need to know. And so as I continue to, go through and read some of the updates, I'm seeing things like, okay, nobody is talking about this.
And I thought about that when I was reading these two articles. I'm like, I haven't seen anything from AAPC or HEMA. And they
Nobody is
email
talking
you
about
all the
this.
exactly.
Like, I don't know. I said, but I guess I will. So
There you
if not
go.
me, then who? Right? If not now, then when?
That's right. And since they're not talking about it, there are a lot of providers who aren't going to be made aware.
Right. And initially I thought, okay, well, this was, in effective in January, but we still in the first quarter. And oftentimes, it takes a minute for stuff to trickle through. It'll be 6 months into the year and people be like, really? I did not know. Okay.
You heard it here first.
You heard it here first. Like, that's a guideline? That's a change? That's a what? Yes, it is. So I'm sure I hadn't seen anything. I did look. There will always be some additional questions and stuff that come up. I think, well, let me just say this. Probably we in such a ride right now. Who got time to pay attention? So maybe that's let's say that. We got some other things to focus on. But as long as these are still here and changes and things that have been implemented, jump on it. It may just help you. All right. So again, I hope this information about the coding changes were helpful for you. I hope we brought you some value today. And
Yeah.
remember, proper coding isn't just about revenue, but it's about accurately reflecting the value and complexity of the care your providers deliver to the patients, as well as their outcomes. That makes it a nice little warm and fuzzy at the end, right?
It does.
And I'm doing good on time. Look at God.
Exactly.
I love it. All right. Well, Mr. Jesse, you have any other things you want to add to the order
No, this
of the
was a
day?
great topic.
Yes.
It really was very informative.
Yes. Like I said, I even tried to bring you into the fold, talking a little bit about patient services. Even though it's the provider's portion of an inpatient service, I still brought you in. All right. Well, I mean, if you really think about it and look at it, even what they're stating as far as the documentation and the conditions, there's some inpatient or some diagnostic gems right there. There's some diagnosis
Yeah.
coding that definitely has to occur, and making sure you follow the appropriate guidelines for those chapters. Infectious disease, cardiovascular services or diseases, all of those things. So it all pulls together.
It does.
It does. Okay. Well, I'm glad you don't feel left out.
Mm.
I thought about you. All right. Well, let me pull up my slide. All right. So, are you thirsty for fresh perspectives on the healthcare revenue cycle? By becoming one of the PRNT sippers, you'll join a community of sharp minds who savor the complexities of the healthcare revenue cycle. Why sip alone when you can steep in knowledge together? Come, let's spill the tea on industry insights. Here's what you can expect as a valued member of the PRNT Sippers. Exclusive healthcare insights. Gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, revenue cycle best practices, and we also throw in some entrepreneurship stuff as well. Y'all check out this last link I put out there this morning. Y'all better get in. Okay. Early access. Be the first to receive expert insights and guides, ensuring you stay ahead in the ever-evolving healthcare industry. Personalized support. Enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And my personal favorite, the community connection. Join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network LLC, which is a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. Oh. So thank you. So thank you for considering becoming a member of the PRNT Sippers. For the cost of 2 cups of tea a month, you can join the community. So check out the link in the description of the video, or you can go to bit.ly/the PRNT Sippers. Again, your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. Yes. That was so nice. Okay.
Yes.
So thank you all again for joining the Saturday morning tea or checking out the replay. Let me ask, like I always do, was the tea spilled today? Put your teacups in the chat. Was the tea spilled today?
Absolutely.
Yes, yes, yes. If I put you up on some game, put the teacups in the chat. I feel like, Ian, if I made you some money, put the teacups in the chat. The technicians need to put it. If I gave you something, put the teacups in the chat. If we brought you some, no, let me stop. Get off the bandwagon. Okay. Now, before we sign off, I got a special request for all you amazing viewers out there. If you found this episode helpful, don't keep it to yourself. Share the knowledge with your colleagues, your frenemies, anybody who can benefit. And you can hit that share button by doing that on whatever platform you're on. And then, hey, why not subscribe to our channel while you're at it, or our page, or whatever platform you're on. You can always follow or subscribe or connect or whatever you do. Like I said, it's so many things out here. I need to know like the lingo for each individual one.
Yes.
To be accurate. Because you know me, I'll be like, just connect.
Definitely.
Just connect. All right. And so stay connected. That way you'll never miss a drop of our health information, compliance, revenue cycle, medical coding, and entrepreneurial tea. Got thoughts, questions, or experiences you want to share about today's topic? Well, we'll love to hear from you. So drop a comment below and let's keep this conversation brewing. And if you enjoyed this episode, give us a thumbs up. It helps more healthcare professionals find our content. Yes.
Definitely.
Also, check out the Coding Nurse channel on YouTube. And are you the Coding Nurse on Instagram as well?
Yes.
Okay. And on Instagram, on all the socials. All
Yes.
the socials. So remember, at the Saturday Morning Tea, we're all about building a community of savvy, informed healthcare professionals. So again, like, share, subscribe, and comment, and let's grow this community together. Mr. Jesse, do you have any closing thoughts?
No, just it was another informative podcast, and I'm just gassed up over that add-on, the infectious disease code. Look, I feel like I work in infectious disease. I'm ready to start, checking for documentation.
Right. And so this is twofold. So not only does this provide us an opportunity to let those who work in that particular specialty know that is here, it's available, and what you need to do. But then think about it on the back end. If you are in compliance, if you are in audit, if you're auditors, now this gives you some things to prepare in advance, because you know it's coming, on what to make sure is there. Hey, if you needed a topic to a risk assessment topic, if this is something that, hey, this may be something that we need to go in and check. Are we getting what we need for this code? Is the documentation here to support? Have we begun using it? You got some data markers right there. Let's do a data dump on whether or not this code is actually being used by our providers. Why or why not? So here's an opportunity. Data analytics people.
Mm-hmm.
We can touch everybody, right?
That's right.
All right. Okay, y'all. Well, this has been a great session today. See you PRNT sippers at 10:15 Eastern Standard Time. And remember, be safe. Oh, can you say the codes one last time? Yes, absolutely. So the codes that we talked about today for the infectious disease specialists are G0545, and that's an add-on code. Again, that's the one for the infectious disease specialist. And then for the cardiovascular risk assessment code, you have what did I do with it? Where did it go? G0537 is for the risk assessment, and G0538 is for the risk management. All righty. All right. Okay, well, y'all, see you again, PRNC sippers, in a minute. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Hope you have a great weekend.
All right.
Bye-bye.
Bye, everybody.